There's an opportunity to develop these metrics also in HCBS, community-based services. So we track quality along the 6 assurance as defined under Section 1915C in the Social Security Act. Those are level of care, the service plan, provider qualification, health and welfare, financial accountability, and administrative authority. So here's a comparison list for community-based services, the description and an example metric, such as the number of providers that meet qualification requirements, the number of findings of non-compliance. One of the observations from this list is that they are very heavily process-oriented, which means we don't see as many patient outcomes here.
In our current payment system, we are able to get our direct care costs paid for, and our staff, which is helping us to bump up our staffing levels over and above what minimum staffing levels are set. And I just recommend, kind of for 2 reasons, that we still keep that in the payment system that's developed. Going with Elaine's comment, keeping people out of the emergency room with higher staffing levels, licensed staffing, professional staffing levels, we'd be more able to do that. But the other thing is, there is a push by CMS for nursing homes to have greatly higher staffing levels of the registered nurse than anything that we've got in Arkansas. And so, with the incentive under direct care portion of our payment, we're also working to please CMS with those increased levels, and that's one of the big weight measurements and weight towards a 5-star if you have that RN staffing.
Good. So thank you for the input. I also hear a question in that comment, and that is whether the nursing staffing ratios have produced the outcomes that you described. So that might be a question that we can return to for the next work group. The implication is, do we see that a nursing home hiring the next staffer does actually produce that concrete outcome? I think we get back to these outcomes either way, but that's a good test of relationship.
We have that answer.
Is that true
We
in Arkansas?
do know that answer, yes, is yes. Over the last 10 years of data, the higher the staffing, the higher the quality.
Is that an aggregate or across nursing homes?
That's an aggregate, but I imagine there's other people here who have done more studies than I only see the aggregate data. So someone else that gets specific data would have to speak to that.
So would this cover that time frame?
Which time frame are we referring to?
Are we finding, so my question is this, are these the high staff nursing homes and these are the low staff nursing homes?
Well, I don't think you can say that. I'm going to take the privilege of answering that because we have facilities that have a high hospice ratio. And one of the outcomes of the dying process is weight loss. Mm-hmm. So you can't just make that, and pressure ulcers too, because if a person has refused a feeding tube and is not eating, there's going to be a likelihood of development of pressure ulcers.
Let me ask a technical question here for a second. Anyone who knows the RUG system well enough, are pressure ulcers and what else did you mention?
Hospice and weight
hospice.
loss.
Are those at all reflected in the MDS? So do we measure that in the MDS?
We measure that, but
does that show up then in a RUG level?
It's not risk adjusted though. They took the risk adjustment away off the current MDS system, 3.0 system. The risk adjustment was taken off.
I'm asking if the RUG system would characterize those individuals differently because they are in hospice. Because
yes.
Okay.
They do. If it's marked on the assessment, that assessment is excluded out of that calculation. For it doesn't say hospice specifically. It says end of life or 6 months or fewer to live, and so those residents.
Does that put you in a different RUG category?
Oh. That I would have to look at all the items that are pulled for the RUG. I thought we were still talking about quality measures.
So here's my point. You have suggested that we need to make sure if there's a quality metric that we're adjusting for the kind of patient that either rates high or rates low. In other words, that those quality metrics would need to be risk adjusted. The second question I infer in your point is the following. Are those characteristics in particular included in the risk adjustment? Should they be? Is the pressure ulcer? I don't know. Is that the fault of somebody? Hospice, you wouldn't, that wouldn't be something you attribute to the nursing facility. But that's a very good question.
Well, Peggy, I would like to say that for the RUG calculation, it pulls out over 100 items, and they're very specific for each resident, but they're weighed heavily on the ADLs. So given the scenario with a hospice resident, their ADL care would be higher. So yes, the answer would be that they would wind up in a higher level of care for their RUG because their ADL care needs would be higher. Now, on the quality measure, that's a different algorithm as far as the way they risk adjust. But for quality measure, they exclude residents out of that calculation.
And let me just say, there's they and then there's we. So what we want to do, and this is where I'm heading with your question, because I think I did understand it, and that is we clearly need to adjust someone's quality rating based on the kinds of residents that you have. And that's just another aspect of the risk adjustment. We wouldn't want to reward someone because they picked all the healthy people and ended up with a high rating. So that's HCBS. So continuing, we actually have some time here, and this is where we are in the process. Is to look at this kind of demarcation, categorization of performance. Performance being one aspect of reimbursement, and identifying these classifications. We don't have to do it this way. Doesn't have to be this way, but got to start somewhere. So we're suggesting, is this the right order where at the highest tier quality performer is really in comparison to peer? The next tier is in comparison to both a minimum level of performance, which means that this process would end up producing a recommended base level of performance. And if you get it, then you're going to get some kind of performance reward. If you meet that and you improve over the last year, you would get more. And if you want to receive the most, then you have to beat your peers. So that's the suggestion. It does not have to be that way. It is not that way for every episode or payment methodology that we're engaged in. And we do not have ownership over this. It's something that we're looking for input, just a place to start.
I'm Liz Blankenship, and I'm a provider of home and community-based services. I actually have two questions. Back in the earlier slides, when you were talking about DCO would determine the financial feasibility, and then you would determine the care setting. What kind of time frame are you looking at to make that determination? Because we're taking care of frail elderly that have multiple chronic issues, and many times acute issues. And so you have someone I'm just going to give you a hypothetical situation. you have someone that's been living alone at home and they end up in the hospital is not going to allow them to stay for 72 hours so they can go into David's skilled rehab that they desperately need, but Medicare will not pay for that. How long will it, but they need to be in a care setting, probably a skilled nursing facility. They don't have the means to pay. How long is it going to take for DCO to determine their financial eligibility and get them into a care setting so that their needs can be met? I'm sitting here and I feel like I need to be the advocate for our elders because, I mean, they have needs that have to be met, but, I mean, there's a long time frame that goes into determining their financial eligibility. I mean, what happens to that?
I'm going to turn to Krista for an answer to that in 1 second, because let me then complicate the whole discussion, and I'm going to time myself. It is. What if individuals under 65 were eligible for some kind of medical assistance or insurance, Medicaid, if they were below 138% of the poverty level, regardless of whether they needed HCBS services? What if those who were eligible under 138% of poverty had available to them state plan-based services, including in the community? In which case, what are we waiting for? Just the assessment of need for those individuals. Now, above 138%, we wouldn't have to wait. So I just wanted to connect a dot or two for those of you who serve anyone that's under 65, that they, with Medicaid-funded private insurance expansion, depending on how that benefit package is designed, they could potentially, decisions haven't been made, certainly the state hasn't decided to expand yet, regardless of what the emails say. It's possible that those below 65 might have access and have already been financially determined eligible before they even need the long-term service, and that's the connection for some of you providers to expansion.
And yes,
that was
Allison,
2 minutes.
Talking about people who've already been financially.
Right. Now I'm going to turn to Krista because you've asked a question about for those, and in between now and 14, but for those who maybe are above 138 and aren't determined yet financially eligible for institutional care, we got assets, etc. I don't know how long it takes.
Our division does not currently do financial eligibility. We are looking to take this over. If you all kind of think back to the very first day, we had our very first long-term care advisory meeting, and we're all sitting there, every different provider type under long-term services and supports. We didn't even know what to talk about until financial eligibility came up, and I couldn't shut y'all up. So it is an issue with every single provider type that provides services for the LTSS population. It takes way too long. It is the most complex, of all Medicaid eligibility categories, and it will continue to take a while. But what we have done and what we continue to do, and we've brought this to the advisory group, is there's a lot of points of delay. Okay, there is getting a medical signature. There is MRT, where it just sits for a long time. There is DCO workers trying to figure out how to get a count of the head of cattle, how to get life policies and this and that type of thing. Well, right now, everything is very siloed, and so if a DCO worker gets an application, a lot of times it kind of just sits there because there's just so many things coming in. So there's going to be a lot of changes. I can't tell you what it will shorten those days to. I can tell you that obviously the goal for the changes that we're making is to shorten that time period. There will be a lot of IT changes. The old answer system that has been operating for decades will change because of the health reform that's coming in, and that will create some kind of efficiencies we are, obviously hoping for. I can't tell you to what degree specifically that will be yet. I can tell you that we have made other changes with regard to getting physician signatures for that, the dementia, code and things like that, so that we're hoping to just carve away at those number of days. So if it takes 72 days today, I don't know what we can shorten it to. I think it's just all of us sitting in and just continually finding those clogs points and figuring out how we can push through them. But it is a hard, very complicated. Legal counsel has to get involved with the estate planners, that are involved now with so many cases. Things are very complicated, and that financial, it isn't going to be as quickly done as the medical. It's just never going to be that way. But because we're integrating all of our software systems, instead of something sitting for like 45 days, as it might sometimes now in these county offices before even letters go out, we will have people who will be monitoring the number of days with flags that will be just kicking off all the time for next steps to be able to prompt that. And the eligibility and the assessors will be working together to make sure we keep moving this as fast as we can through the pipeline.